and then we start. Okay, we are at 70 participants now, so we are still growing rapidly. We are breaking the 100th barrier now.
Yeah, with Tulio, we were expecting thousands.
Yeah. We have to break the 1,000 barrier again. We have only one talk that reached that level so far. Okay, but we are still increasing. 100 is behind us. Let's wait a fraction more. Okay, this numbers are still slowly increasing. Okay, we are almost 110 now. Okay. Okay, I think the curve is flattening, so maybe we can slowly start. Okay, then good morning, everyone. Thank you very much for joining us at this edition of Data at Breakfast on a very cold morning, unusually cold morning in Durban. This morning, we are very happy to have again two of the traditional stars of the recent Data at Breakfast, Richard Lessells and Tulio de Oliveira, and they will be reinforced this morning by Professor Yunus Moosa. And Richard and Tulio work at KRISP in the medical school, and Professor Moosa is the head of Department of Infectious Diseases at UKZN. And this morning we are very lucky that the three of them will speak about a report that they wrote recently about the outbreak of COVID-19 at the St. Augustine's hospital. And they wrote a report about this event that caught the worldwide attention of the best science journals in the world. And if you had the opportunity to peek into the report, you know that it reads like a thriller. Yeah, so this morning we are very happy to have them share their experience with us. And I think they will, Richard, if I understand correctly, is the first, will start and will be then followed by Tulio and Yunus. So Richard, I will give over to you. Thank you. Sorry, one last comment. The Zoom has a question and answer facility. I always forget to mention that. Please make use of that. And Richard, Tulio, and Yunus will monitor the questions, and at the end of the presentation, they might have time to answer some of your problems. So thank you very much, Richard, Tulio, and Yunus, for being with us this morning, and over to you. We are all looking to hear from you about the outbreak in the St. Augustine's Hospital.
Great. Thank you, Francesco, and thanks for asking us again to talk and to talk on this topic. Just to check, you can see my slides, okay?
Yes, it's perfect. Thank you.
Great. So what we're going to do today is just walk through a little bit this outbreak investigation that we did at St. Augustine's Hospital, a large private hospital here in Durban. Really just try and flag up both what we did specifically for this outbreak of COVID and how it helps us to understand a little bit about how the virus spreads in closed spaces. And while the findings from this investigation are largely relevant for hospitals, it also gives us some insight into why these kind of outbreaks or clusters of infection are happening in different places, not just hospitals, but also workplaces, factories, prisons, other institutions, and essentially any place where there's kind of closed spaces, people in crowded spaces where the physical distancing is challenging. And I think that's becoming more important and more obvious, certainly in KwaZulu-Natal, that we're still seeing most of the transmission is happening in these kind of clusters of infections. So as Francesco said, I will start and just walk through a little bit about this outbreak investigation, and then hand over to Tulio and Yunus to take us beyond that. So one of the things just to explain is what we mean when we talk about an outbreak investigation. We're talking here about an outbreak of an infectious disease in the hospital. And essentially what we're trying to do when we do an outbreak investigation is to understand how that infection got into the hospital and how it spread through the hospital and how it affected a number of people in the hospital. And you're doing that for two reasons. You're doing it, first of all, to try and understand how you can stop that outbreak. So what can you do immediately to stop the outbreak and prevent more people getting infected? But you're also doing it to learn, how did this happen in the first place? What were the prevention strategies in place, and what were the gaps or the weaknesses in those that allowed this outbreak to happen? And that then allows you to put in place measures to try and stop this happening again in the future. So when we came in and were asked to do this outbreak investigation, which was at the beginning of April, these were essentially our goals and what were guiding us throughout this. So to do this, you need to spend quite a lot of time. And we were asked to do this on the 4th of April. So the beginning of April was when this outbreak was kind of apparent. And in the end, because it became bigger than we first thought, this outbreak, we spent quite a lot of April in the hospital working with the team there to understand what had happened. Because you have to do quite a few different things to try and get an accurate understanding of what happened. So these are just some of the methods that we use when we do an outbreak investigation. So we have to look at patient charts to understand what was wrong with patients, what they came into hospital with, where the COVID fit in their hospital stay. We have to understand the structure of the hospital and the flow of patients, the flow of staff around the hospital. That's particularly important at somewhere like St. Augustine's Hospital. If any of you know the hospital, it's a bit of a maze. I get lost every time I'm in there because it's a very old building, and so you have to understand how people move through the hospital. We talked with some of the doctors and other staff that were looking after patients to understand what their thinking was at different times. We have to review some of the policies and procedures of the hospital to see what was in place at the time that this outbreak was happening, and but to discuss a lot with the hospital management and the infection prevention and control team. That's IPC, infection prevention and control, to understand the kind of prevention measures that were in place at the time. And then the one very technical aspect that complements everything is what Tulio is going to talk about, which is the sequencing of the virus, and then genetic phylogenetic analysis, which helps you to understand the infections and how the infections are connected, and helps you to understand how the virus spread through the hospital. So just to give you an overview of this hospital outbreak, this graph is what we call an epidemiological curve, or an epi curve for short. And essentially, this is what you can do for any outbreak, whether a hospital outbreak or an outbreak in the community. And it's just a pictorial display of all the cases that are related to that outbreak. So here, what we have is just all the cases that were diagnosed with COVID from the beginning of March to the end of April. So your x-axis is just time, and starting at the 9th of March. If you'll remember, the first case in the whole of South Africa was reported on the 5th of March. So here we're at the very beginning of the epidemic in South Africa. And then each of these blocks is just one confirmed case. And you can see there's a few different colors, which is just explaining the different types of cases. So in this light orange, you have staff members, and then the other colors are all patients and different types of patients. And we won't go into too much detail about that, but just to explain, the first 3 patients here were what we would call outpatients. These were people that just came to the hospital to be tested for COVID. They had symptoms and they wanted to be tested, and they weren't admitted to the hospital and didn't stay in the hospital. So this is something that we use just to give us an understanding of the pattern of the outbreak, and helps to guide your thinking about how it may have spread. So, and this is just to show when we came in, which was the 4th of April. And these dates are the dates that the sample was collected, not the date the case was reported. So when we came in to start this investigation, there were roughly about 13 cases reported, and 2 of those cases that unfortunately resulted in death. But by the end of this outbreak, we're talking upwards of 100 cases, and majority of those in the end were staff members. So just to give you a sense of the size of the outbreak. One of the first things we did the first weekend that we were asked to go in, what you normally start doing with an outbreak investigation is what's called a line listing. So there, essentially what you're doing is just listing each case that you're aware of that's been diagnosed in that hospital, and just getting some basic details of each case. So you're trying to understand when was that person admitted to hospital, what was the reason they were admitted, when did they become symptomatic of the infection you're thinking about, in this case COVID, when did they test positive. One of the things when we started doing this that we recognized very quickly was that people move around the hospital a lot. Patients are moved around the hospital a lot, so they move between different wards. So where we would normally just do this perhaps as a spreadsheet, just with details, with one column of which ward people were on, we actually realized we needed to do something like this, where we could show the movement of patients between different wards. So what you have here is still a line listing. So each line here is a different patient or a different case of COVID. And then along the top here is your timeline again from the end of February to the beginning of April. And then each block here in a different color is basically time that a patient has spent on a different ward. And so each different color is a different hospital ward. These 3 at the top with this green color are the people that weren't admitted to the hospital, but just attended the emergency department to be assessed and investigated for COVID. So the reason for doing this, and one of the things that you can probably see here, the reason you're doing this is to try and visualize patterns in the data. So what we're essentially doing here is to start to understand these first cases. How could it be that they were infected with COVID? So you're trying to look for overlap in time between different cases. So what you can start to see here, if we look at this line here, which is P3, which is actually the first patient in the hospital, an inpatient that was found to have COVID. What we're looking at here is what had happened to her before she was diagnosed with COVID. And one of the things that was very striking immediately was that you can see here that she overlaps with this first case who attended the emergency department. They are in the emergency department on the same day. And so that alerted us to a potential overlap in time and space. We also noticed that for a few of these cases, there was overlap on this ward, which is the light blue ward, which is one of the medical wards. And then we noticed that later on, there's some overlap in this light purple, which is one of the intensive care units. So essentially, you're starting to see some patterns in the data that help you to understand how the virus might have spread around the hospital. When we were particularly focused on this, how the virus came to get into the hospital in the first place, I said that we could see there was overlap in time and space between this first patient who was assessed at the hospital and somebody who later became the first case of an inpatient in the hospital. And so that was something that we then drilled into in much more detail to understand, okay, there's overlap in time and space, but can we see any plausible way that the virus could have spread between these two people? And so to do that, that meant going to the emergency department and really understanding the detailed movement of those people in the emergency department and the exact timings to understand, was there a plausible mechanism by which the virus would have got from one person to another. And to cut a long story short, essentially we found that there was a plausible way that the virus may have got from this first patient who was being assessed in the emergency department to this second person who was being admitted for a completely unconnected medical problem with a suspected stroke, but was in the emergency department at the same time, and they were quite close physically. So what you see here, when this first gentleman comes to the hospital, he's screened at an outdoor screening station, which many of you will be familiar with now. If you're coming into hospitals or into workplaces, you're getting screened as you come in to see whether you might have symptoms or might have had a contact with somebody with COVID. And this was already operational at the hospital at the beginning of March. So this person was screened appropriately. He had recently returned from traveling, most recently the UK, and he reported this travel history, and he reported his symptoms of cough and sore throat and fever. So he was appropriately moved into an isolation area, a separate room in the emergency department. And that meant that he was taken in a side entrance, not the normal entrance to the emergency department, and put in a separate isolation room here. And that was a good idea, to have this separate isolation area where people could be seen, where healthcare workers could wear the appropriate protection and see patients in a specific area. Unfortunately, the one drawback to this was that to get to this room, you still had to move through a part of the main emergency department. And here is what we call the resuscitation bay, or the resus bay, in the emergency department. So this is where often the very sick people come when they first enter the hospital, to be kind of resuscitated, to have initial measures taken to stabilize them before they're admitted to a ward. And so for this gentleman to get in, he had to come through this area. And when he comes out of this area, he also has to move through this area. And what we could find when we dug into where these people had been and when, was that they overlapped in time. And the lady that's being admitted to the hospital with a suspected stroke is in one of these trolleys, almost directly outside this room where the gentleman was being assessed. And so this helped us to say, although we won't have definitive proof, there's certainly a plausible explanation for how the virus might have got from one person to another. So it might have happened directly from him coughing as he exits this room, or it might have happened that a healthcare worker, one of the people involved in looking after this gentleman, could have transferred the virus to this other patient here, or it could have traveled on a piece of medical equipment or some other surface to get between one person and the other. So this gave us an initial understanding of how the virus might have come into the hospital. What was then important was to follow this first case through to understand whether this made sense. If she was exposed to the virus there, did that make sense with what happened beyond that? And so here you see what is essentially just a more detailed timeline for this one case, to understand what happens beyond this possible exposure in the emergency department. And again, to cut this short, essentially what we found was that the progression beyond this point was consistent with her acquiring the virus at this point in the emergency department, because she develops some symptoms. She develops a fever about 4 days later when she's now in one of the medical wards. She only gets fever. She doesn't get any other symptoms, any cough or sore throat or breathlessness at that time. And she actually only gets a one-off fever, which then settles. And she's well enough to be discharged home. But then a couple of days after being discharged home, she becomes more unwell. She becomes dizzy and is noticed to have a low blood pressure. And then a couple of days beyond that, she becomes much more severely unwell with fever again and breathlessness. And she's readmitted to the hospital and is found to be very, very unwell, and is found to have pneumonia involving both lungs. And almost immediately on readmission, she requires what we call intubation and ventilation. So she requires to be put on a ventilator to support her breathing. So when we looked at this timeline, this was fitting with what we understand about the natural history of COVID and the time it takes between being infected to becoming initially symptomatic and then becoming very severely unwell in the more complicated cases. So this to us supported this hypothesis that she may have been exposed to the virus in the emergency department. The other thing that supported this was that one of the first staff member to become infected in the whole hospital was a nurse who became unwell around the 17th of March. And when we looked at this nurse and where she had been working, we found that she had been working in this ward, this orange ward, and had been caring directly for this patient, P3, on the night of the 12th into the 13th of March. And so things were starting to come together and to have an explanation of how the virus started spreading in this hospital. By the time we'd been there for a little bit of time, the numbers of cases started rising. So each day we were there, there were a number of new cases identified. And a lot of that was coming from systematic testing. So once the hospital realized the size and the extent of the outbreak, they decided that the best strategy for them was to test everybody in the hospital. So to test all the patients in the hospital and to test all the staff members, because that was the only way they would get a real understanding of the extent of the outbreak. So that was obviously a huge undertaking because this hospital is a very large hospital. And so that meant every day there were a number of new cases identified. And unfortunately, each day there were also often one or two new deaths. And I mention that just to give you a sense of how difficult this kind of process can be and how harrowing, because while you're trying to understand and investigate this, events are unfolding. And it's very difficult for the staff that work there and the staff that are responsible for that hospital when they become aware of the real extent of the outbreak and the impact that it's having on people's lives. And so that's really just to give you a sense of the process. This is essentially the same line listing then, but now essentially up to the end of the outbreak with all the cases, all the patients that were confirmed to have COVID in the hospital. And again, this is just to show you that this was used then to try and understand the overlap in time and space, and to put together a more detailed explanation of the total spread through the hospital. And to come to this diagram, which looks complicated, but I try and walk you through it, this is essentially what we ended up with as our understanding of the most likely chains of transmission. So the most likely way that the virus spread through the hospital. And so just to orientate you here, along the bottom again is the timeline from the beginning of March to the beginning of April. And then what you see here, each of these colored blocks, either a square or a circle, is one case, one patient, or one healthcare worker, is these hexagons. And the different colors again refer to the different wards. And essentially what we're trying to show here is how the virus moved from one patient to another patient, or from a patient to a healthcare worker, or from a healthcare worker back to a patient. And essentially what you see here is what we understood was that the virus spread in clusters on different wards in the hospital. So you can see here, this is our initial introduction of the virus when we think it transferred from this first gentleman being assessed in the emergency department to this lady being admitted for an unconnected reason. And then we think there was a chain of transmission. So the virus then infected a number of people on one of the medical wards. And then later you see a cluster of infection on the medical intensive care unit and the surgical intensive care unit, and some smaller clusters of infection on other wards, neurology ward and surgical ward. What you also notice is that what we were able to understand, if you remember back to my explanation of this first case in the hospital, she actually had 2 different admissions. So she was admitted initially and then discharged to a local nursing home and then readmitted to the hospital. And what we could show is that actually there was some transmission of the virus in the local nursing home while she was there. And there were 4 other people that became infected in the nursing home. So essentially what we would call a linked outbreak or a linked cluster of infections. And at the end here, you see another kind of cluster of infections in gray. And what this was that while we were at the hospital investigating this outbreak, unfortunately, we were made aware that there were also infections being recognized in the dialysis unit, which is kind of a separate unit which is on the same campus as the main hospital at St. Augustine's. It's run under a slightly different organization. But what we could show was that some of the people who were infected in the hospital were then were discharged from the hospital and were then attending the dialysis unit as an outpatient and became exposed other patients and staff in the dialysis unit to the virus. So once we had this understanding, the other question we then ask ourselves is, can we understand how the virus spread? So here we've explained where we think it spread and between which patients. But we really want to then understand how it spread, because that helps us to understand how it could have been prevented, how we prevent it happening in the future. And here, to do this, what we need to do is really drill down into the detail and understand where people were located on different wards at the time when we think the transmission occurred. So here's just a couple of examples. Here is one of the medical wards. And here we're showing you a floor plan of the ward. And these are the different beds. So here you see a kind of shared room with 4 beds in it. Here you see some single rooms. And the red here is a person who is at that time thought to be infectious with COVID. And the green is somebody who we think was exposed to the virus at that time, was infected with the virus on this ward. And so we're showing here that in some instances, people were located very close. So here's one person who's infectious and one person who becomes infected, and they're in the same room, in bed directly opposite. So here it would be plausible that there was direct transmission of the virus. And Yunus will talk about the mechanisms, but direct droplet transmission of the virus. But there are also a few people who become infected here in this separate room. And so that doesn't make sense that that would be direct droplet transmission of the virus, because generally in hospital, people people don't mingle very much. People are confined to their bed, usually, if they're sick enough to be in hospital. And so the virus had to find a way from this area down the ward and into this room, okay? And that is unlikely to happen directly through the air, and therefore suggests that something had to take the virus from this room to this room. And that our understanding of that is that that's most likely to happen on healthcare worker hands, or on some piece of medical equipment, whether it be a stethoscope or a thermometer or a blood pressure cuff, something that's being used on multiple patients and may not be being cleaned thoroughly between each patient. So that helps to give us an understanding. This is another example from one of the different wards. Same thing here, so you see different organization of beds, some shared areas, some single rooms. And again, you have some people who are infectious and then other people who are exposed to the virus. And this example is just to show much more widespread infection on this ward, where a number of people were exposed to the virus. And again, it's people in different areas of the ward, which makes spread through the air much less plausible, and means that it's very likely that this virus was spreading on hands or on surfaces and on medical equipment. Just to briefly explain to you, one of the reasons that this outbreak got a lot of attention at the time was, unfortunately, that there were a number of deaths in the patients that were infected with COVID. And that's unfortunately a reality of hospital outbreaks, because people that are in hospital are inherently a vulnerable population. They're in hospital for a reason, because they have illness. And if they get an infection on top of that when they're in hospital, then often that can have very serious consequences. And what we saw here was that there was a very high case fatality rate amongst the patients that were infected. But most of the people that died had a number of what we call comorbidities. So they had a number of other illnesses, and often those were the illnesses that have been associated with a higher risk of dying from COVID. And that's things like high blood pressure, diabetes, chronic kidney disease, chronic heart disease. And this, we mention this just to explain why preventing hospital outbreaks is so important, because the people in hospital are very different from the general population. And if you get hospital outbreaks, you're unfortunately going to get deaths from that. Just briefly to touch on the infections in the staff, in total, there were 80 infections in staff at this hospital. And that sounds a lot and is a lot of infections. But as I said at the beginning, this is a huge hospital, actually, with almost 2,000 staff in total. So of all the staff that they tested, this 80 translates to about 5% of all people tested. Most of the staff that were infected, not surprisingly, were nurses or nursing students. But there were some infections in staff that were not in direct patient-facing roles. So what we mean there is people that don't have hands-on contact with patients. So that's some administrative staff, cleaners, kitchen staff. And Yunus will touch on what this means to us and what we're learning from other hospital outbreaks. as to how transmission can happen between staff. Largely what we saw was that the staff infections correlated with the patient infections, that the wards where there were a lot of patients infected were the same wards where there were most staff infected. And this again supported our hypothesis of how the virus spread through the hospital. There were no infections documented in the staff that were working in the COVID areas, in the COVID intensive care unit, which you might consider to be the highest risk area in the hospital for staff becoming infected. And again, Yunus can touch on that. And importantly, there were no deaths reported in staff. I'm going to skip through this, and we can come back to it if there's questions later. This is just showing this separate kind of evolution of the mini outbreak in the dialysis unit. And again, just showing that really has very severe consequences, because again, people on dialysis are generally very sick people, and any infection like COVID can have serious consequences. And I was talking to somebody just yesterday who's telling me of other similar outbreaks in other dialysis units around the country. And I think this is a particular area to focus on to try and prevent infection getting into dialysis units. So I'm going to come to a close there and just show you again this diagram, just to say this was where we ended up, Yunus and I, who had done a lot of the groundwork to understand what happened in the hospital, come up with this hypothesis of how the virus spread through the hospital with these separate waves of transmission on different wards within the hospital, and that it linked to clusters of infection in a local nursing home and in this dialysis unit. And so when we added these kind of linked clusters to the main hospital outbreak, we estimated that up to 135 infections may have arisen from this single introduction of the virus to the hospital. And just to put that in context, by the time these infections were all documented by the end of April, that number would account for around 1 in 7 of all cases in the province, in KwaZulu-Natal. So quite a significant contribution to the overall epidemic in the province. So I'm going to hand over to Tulio, who's going to explain to you now how the genomics and the phylogenetic analysis then takes this on and kind of helps us to understand, is this a correct hypothesis, or is this completely wrong and we've misunderstood the transmission of the virus completely?
Sorry, I'm just putting ethanol in my hands because I'm gonna touch Richard's mouse. Yeah, and one thing that we know from studying hospital outbreaks, it is that a lot of time keyboards and mouse are the place that have the highest amount of the virus. Yeah, but then going back to that, so it's quite clear that Richard and Yunus come with a very strong hypothesis that could be tested. And why we needed DNA data or genomic data to test that hypothesis is because here the main hypothesis is, as Richard said, one unique introduction that spread during the hospital in different waves. Yeah, and one of the discussion that people have said, but are you sure that was one introduction? Maybe was like 20 or 30 introductions, and each person got this virus in the community and came to the hospital. And that was quite important to understand the source if it was one virus, one lineage, one introduction or not. Yeah. So that's what we did. So let me show you how that is done. Okay. So to ground you, here it's analysis of sequence data or DNA data. What I have here, it is a phylogenetic tree. And here on the left, I have the different countries with a different color code. And just to understand the axis here is number of mutations that accumulated from the original strain. And you will remember that the first strain that was sequenced was a strain in Wuhan by January, to be more specific, 11 of January of 2020. Yeah? So one thing to see is that from the original strain, you have this linear number of mutations that are added. And this strain after was introduced in multiple countries. So before we go to the outbreak, what we also did in that week is to get access to random samples from that of COVID infected people from Durban. And if you go up here, you're gonna find our first one that we call KRISP 006. And that seemed to be an introduction of SARS-CoV-2 in Durban associated with Australia. If you go up, you will find another one here, KRISP 002, is another introduction of SARS-CoV-2 into Durban, but coming from Europe. Yeah, so we have two independent introductions. And if you go up, you have another one, 3, 4, 5 introductions, that again from European cluster. So what we did is by just showing that if you get 5 random individuals in the vicinities of the hospital, or what you call the environs, you would find 5 different introductions. And for the ones following the news, yesterday the UK have highlighted that they had at least 1.3 thousand introductions in the UK. And in South Africa, we will have probably a similar number of introductions. So you have all these introductions, but then here we come to the big cluster of the hospital. I'm gonna zoom on that so we can explain to you. One thing that we can see is that from this data, we have generated 18 whole genomes of the virus, and all of the 18 whole genomes of the virus of the hospitals, they form a monophyletic cluster, a very tight cluster of almost identical sequence, which really supporting like an initial unique introduction to the hospital. We have a number of important patients. Here is patient number 3 that Richard described in detail. That was the first patient to be infected in the hospital. Yeah, and then what you have here is that during this month-long infection, the hospital, it added 1 or 2 mutations to the virus, which is completely in line with the evolution of the virus. But this is just adding a different mutation to the same background. And then what we have here is a cluster of healthcare workers, yeah. And if you remember what Richard said, a lot of them associated with the main wards that you got infection. An interesting thing here, we could also find a very clear relationship of the same virus that was introduced in the old care home. Just showing, confirm the hypothesis of Richard and Yunus, 1 introduction widespread in the hospital across patients and health staffs associated with their ward, which is seeding secondary introductions, in this case set in the old care home. So just quick to go to you, is that the way that you analyze and that you support or refute hypothesis of nosocomial outbreaks? Yes, it is, and I'm gonna highlight here from you some previous work that we have done in the past with other 2 viruses, yeah, HIV and hepatitis C, that caused a big outbreak in a Libyan hospital, yeah. So this was an outbreak that infected quite similar, was a nosocomial outbreak. 418 children were infected either with HIV and hepatitis C. 6 medical workers in that case were charged with deliberately infecting the children in 1 event, in 1 night, and they were put on jail, and they were going to be executed through through the panel system. Yeah. So here was the hypothesis that we have to test. Yeah. In this case, that was a one event. Yeah. That infected all the children in a given time. What we did is to generate very similar what we did from this hospital. We generate sequence data from HIV and hepatitis C at similar frequency, around 10 to 15% of all the infections, to see if we support or refute that hypothesis. And what we show here, just it is the opposite that we see in our hospital here. Yeah, we rejected the hypothesis of a unique introduction. Yeah. And what you supported is a hypothesis, it is of multiple introductions in a long-lasting nosocomial transmission. So just to get to you, we had one cluster of HIV, but we had another from hepatitis C that's more transmissible by infected medical material. You had 1, 2, 3, 4, 5, 6. So if you put together, it seems that you have at least 7 different strains infected these children of these 2 viruses, which supported multiple and long-lasting introduction on the outbreak. Yeah? So that's what we did. In that case was the opposite. Yeah, we had a clear hypothesis that was refuted with sequence data. And in the end, the medical personnel, they were considered to be innocent and they were released from jail. Yeah. So we do that also for other viruses. So as I show you, we show here with COVID, with SARS-CoV-2, HIV, hepatitis C, but in the last few years, we have done a lot of outbreak investigation of Zika and yellow fever, for example. Yeah. So now I'm gonna pass to Yunus, which will talk about what we learned from that.
Thank you very much, Tulio. All right, so for us to understand what lessons we've learned and why we recommend what we do, it might be a good idea to just review how this virus is transmitted. Essentially, an individual that is infected, the virus leaves that individual whenever they speak, because the main area where the virus is housed is in the upper respiratory tract, in the nasopharynx and oropharynx. So that virus gets mobilized out of the infected patient when the patient coughs, sneezes, speaks loud, sings, etc. And it comes out in a spray, a very fine spray of saliva that is microscopic. So nobody actually feels this spray hit them, but it's in the air around the patient. So when the spray leaves the infected patient, it can either remain in the air as droplets, and if it does, then anyone that is in the close proximity of the patient could get infected when these droplets land on the T-zone of the patient's face. It's either the eyes, the nose, or the mouth. Or the spray will then land up around the patient on inanimate surfaces around the particular patient. For example, on surfaces of the tables, computer laptops, on the telephone, etc. When these sites where the spray has landed are touched by an individual, then that organism or the virus gets onto the hands, can either infect the individual when they touch their nose or face, or can be transmitted to anyone else when those infected or contaminated hands touch those people. So clearly this virus will spread when the patient is in close proximity to another individual that's not infected. So the main issues or the main setup that transmits this virus is when people are in closed spaces, they are crowding of individuals, or there is close contact between individuals. So keeping that in mind, let's look at, for these viruses to be transmitted, obviously they need to be viable when they are in these places. So just give you a sense of the viability of the virus, is that when they touch certain surfaces, they could actually remain infectious for a few days, depending on the temperature, the humidity, and the nature of the surface. There has been in vitro studies, that is studies not involving humans, but experimental situations, where have demonstrated that the virus could be viable in the air for a few hours, although that is being refuted because it has not been shown in real life situations. So clearly this virus remains viable for a time period in the environment of the patient. Now, when we go to hospitals and see how hospitals practice, you will realize that hospitals create the perfect storm. It is a situation where patients are in close proximity of each other. They are in a close space, and there is contact. The nature of the way patients are cared for in hospital means that there are staff that would be making contact with infected patients, as well as making contact with non-infected patients, as well as staff making contact with each other. Therefore, creating indirect contact and fomites, which are inanimate objects that are contaminated with the viruses that can be moved from patient to patient and between wards. What was also important to remember in our situation is that there was a delayed recognition of the individual that was infected. And that delayed recognition resulted in very rapid spread of the virus in the hospital, as well as secondary spread to other areas. Our index patient had moved to the nursing home and created an outbreak in the nursing home, clearly suggesting that it is critical that individuals that are infected are detected early and isolated as soon as possible. Another major challenge is that there is this concept of pre-symptomatic transmission, which was actually demonstrated by our first patient that was found in hospital. She was virtually pre-symptomatic or very mildly symptomatic when she was in the medical ward prior to being discharged. She was in the medical ward from around the 13th to the 16th, and in those 4 to 5 days had already transmitted infection to at least 5 patients in the medical ward, suggesting that these patients can remain very subtly symptomatic and are at risk of transmitting and can be difficult to detect. The other important thing to realize is that not only nursing staff are at risk, but staff other than nursing staff that have minimal contact with patients could be a problem. So what this tells us is that you need an extremely high index of suspicion, and that all staff should be considered potentially infected, and therefore you need to have a very high focus on symptoms, because that's the only thing that we can use to tell us that an individual is infected. We need early recognition and therefore early isolation of patients to limit transmission. And important is that if individuals are tested, we need to get results as soon as possible, and therefore these samples should be prioritized when it comes to testing. The other important thing to remember is that not having strong IPC systems, which St. Augustine's Hospital did have in place, but also very strong IPC practices. So it's important to emphasize the risk of indirect contact as well as fomites. And we often don't consider door handles, stethoscopes, pens as being fomites. So it needs to be emphasized to all people in hospitals as well as out of hospitals, in areas such as malls, in areas such as homes, nursing homes, etc., that fomites are an important risk. Hand hygiene is critical. I mean, this virus doesn't fly all over the place. If it is, it's in the vicinity of the patient, or it's on patients' hands. So it is the hands of individuals that transfer it from person to person. Hand hygiene becomes very critical, and it's important to realize that when patients wear gloves or when individuals wear gloves, they have this false sense of security that everyone and everything around them is safe. What's important to remember is that the gloves will have these droplets on them, and even if you have gloves on, you should be washing your hands or removing the gloves between patients. PPE is always emphasized, and it's important to realize that PPE is important, but it's only one aspect of infection prevention and control. What is also important is hand hygiene and social distancing. So it's important to remember that the environment around the patient can be contaminated. So it is important to clean those areas regularly. The environmental hygiene is important, and it is important to have somebody monitoring that this cleaning is done and the cleaning done properly. Fomites should also be managed. Doctors' stethoscopes are often forgotten, BP cuffs, etc. So it's important for these to be actually restricted to the use of one individual patient. And if they're going to be moved from patient to patient, then they need to be adequately cleaned. So you can see that one of the most important ways in preventing transmission is not allowing the infected to come into contact with the non-infected. So we have actually recommended that within hospitals is to try and demarcate areas where the infected are kept, the potentially infected are kept, and where the non-infected are kept, and to minimize the crossover of patients between these various regions. And the only way to do that is to separate these zones and clearly demarcate these zones, which can be a challenge because many hospitals have been designed and are old hospitals. So it can be difficult to keep these areas separated. But it's important to try as far as possible to designate these areas in different colors, warn people when they go from one of these areas into the other areas about infection prevention and control, and as far as possible to try and maintain these areas as separate as possible. Also, if you look at how wards are designed to create crowding because we have these general wards where we have between 4 and 6 beds within that area. And that should be discouraged as far as possible, possibly separating the beds by at least a couple meters and or creating partitions between beds, limiting the movement of patients between wards, limiting the movements of staff between wards, and in emphasizing social distancing, not only when there is contact between patient and staff, but also between staffs when they mingle during social activity, to emphasize that tea rooms, when staff transport each other together, they often share the vehicles that they use to go to work. All of this needs to be taken into account and emphasized. So finally, I'd like to thank the staff at the hospital that helped us do this detailed investigation, and without their close cooperation, we would never have been able to achieve this degree of understanding of the outbreak. In the interest of time, I will stop there and hopefully take some questions. Thank you.
Thank you very much, Richard, Tulio, and Yunus, for this really thrilling exposition of this case of outbreak of COVID in one of our local hospitals. Maybe one day we will watch it on Netflix, and it will have more viewer than Prison Break, and it will call Hospital Outbreak. But I see that there were a few questions in the Q&A. Would you like to answer some of them, or would you like me to share some of the questions with you?
Yes, we're happy to take some of the questions. All three are here.
Okay.
Do you want to read the questions out? How would you like to do this?
As you wish.
All right, let me read out the question and then one of us will take them. The question is, besides people moving around the hospital and spreading the virus, what are your thoughts on the toilet plume phenomenon? Now, I'm not too familiar with the toilet plume phenomenon. Are you, Richard? It's called the toilet plume. Well,
I don't know the exact name, but people are worried about contamination of toilets.
Okay, so if we are looking at contamination of inanimate objects, clearly this is a concern. And we usually encourage, especially in the setting of hospitals, and that might extend to other closed areas like schools, universities, malls, etc., is that they should clean these inanimate surfaces as often as possible. The preference would be to clean them frequently enough so that each time somebody else touches that surface has been cleaned. But that can be challenging. So the recommendation is to clean it as frequently as possible. So you would use an alcohol wipe to clean these surfaces each time an individual touches it. We often say that between 3 to 4 times a day, or as frequently as possible. So that is a real phenomenon, and that should be taken into account. Is it not possible that staff pick up the virus and brought it into hospital from the community areas that they reside in? That is a real possibility, and I'll allow Richard to actually speak to that. Richard?
So that was certainly one of the thoughts we had was could it have been multiple introductions that different staff members were bringing the virus in from the community. The reasons that we don't think that was the case, the first reason is that this was all happening at the beginning of March. And we know that actually, based on the evidence we have, we think there was very little community transmission at that time in KwaZulu-Natal. And there's still relatively little community transmission now. And the genomic analysis that Tulio showed, we didn't pick up any other introductions of the virus, any separate introductions of the virus in healthcare workers. Now, of course, we didn't get a sample and a DNA sequence from every virus, from every healthcare worker. So it's possible that we may have missed other introductions, but all the evidence we have points to it coming from this single introduction and then spreading. And the other point to make is that most of those staff that were infected were picked up during this systematic testing. So they were tested because everybody was being tested and not because they were symptomatic. And so at the time of testing, many of the staff, probably most of the staff, were actually asymptomatic. They didn't have any symptoms. Quite a few of them then developed symptoms after they had tested. So we didn't have a lot of evidence of healthcare workers with symptoms coming into the hospital. And so all these things together kind of make us think that that's less likely that lots of them brought the virus in from the community.
All right, the other question is that did patient 1 survive? Yes, patient 1 was the first person that brought in the virus, came in as an outpatient, had mild symptoms, was seen at the hospital, tested and sent home. And from what we could determine, he recovered slowly over time and did perfectly fine. Another question was around the use of masks, the cloth masks. It's important to understand that the cloth mask is one method in which we are trying to prevent spread of the infection, and that is considered source control. In other words, individuals that have asymptomatic or pre-symptomatic viral shedding, when they wear the masks, they will reduce the spray of infected droplets to approximately 50% of what it would be if an individual wasn't wearing the mask. So it's not protecting the individual that is uninfected, that is standing in close proximity to an infected person, but is protecting the infected person from spreading the virus out. So these are various measures that we've put in place. None of them are 100% perfect, to try and reduce the risk of transmission as much as possible. And sure, there are concerns about people who wear these masks that might limit their ability to breathe out and in properly. But I think we just need to be sensible about the use. And if you are not in any close proximity to anyone around you, you can always move the mask so that you can breathe better. And that if you're going to be within 2 meters of another person, then slip the mask back on. Good morning. What could be the reason for the ICU staff not being infected, and how come they put death amongst the hospital staff? Were not having any comorbidities. Sure, you must remember that the mortality amongst individuals that have comorbidities are not 100%. People who have comorbidities do die, and their risk of dying is higher than people without comorbidities, but it's certainly less than 20%. So there are individuals, when they get adequate care and support, they could survive this infection. The concern about the ICU staff actually emphasizes to us that the ICU staff were probably practicing good personal protective equipment, and therefore had reduced their risk of getting infected. So it just tells us about how effective PPE is when it is used properly. We've gone beyond time. Francesco, do you want us to continue with questions, or how would you like to proceed?
Maybe there is one question that I think is very interesting, which might be a little bit technical, and it was about whether there are uncertainties in the phylogenetic trees, and if there are, how can they be described? Maybe it's a question for Tulio.
Yes, go ahead, Tulio.
Okay, so yeah. So one of the reasons that we are quite confident about the phylogenetic analysis, is that we did that in stage. What mean in stage? Yeah, we generate 9 genome of the virus, yeah, and they all cluster together with almost no difference. And then we double that to 18, and again they all one introduction with very little mutations, yeah. So as we are finishing the paper now, we probably have close to 40 or 50 genomes of the virus. And again, they paint exactly the same picture, yeah. And that normally it is very strong site, yeah. As you go adding data, yeah, that the results are very similar, yeah. So that's one of the main points. The second main point to highlight it is that's the most appropriate way to use genetic data and phylogenetics. That's to support or refute a hypothesis, yeah. And that's why it was so important, the work that Richard and Yunus did, completely independent from our work in the lab, yeah, and completely in parallel for what was done, yeah. So together we really supported the hypothesis, yeah. In relationship to the virus it is a virus that was originated around the best time estimates around like end of last year, around November last year, was first sequenced in January. So what it means is that it had very little genetic diversity. What we know is that it's accumulated 2 mutations per month, yeah. But what helped us in the phylogenetic analysis of this data is what I showed before, the multiple introductions. So you have more variation in a geographic area that was caused by multiple introduction of virus that evolved separately in different areas, yeah. And that's what allow us to use phylogenetics to understand transmission patterns and seeding and level of community transmission.
Okay, I think on that note, since we went a little bit over our usual time limit, I think I would like to thank again very much Tulio, Richard, and Yunus for this really extraordinary report on the outbreak of COVID in a hospital. It was really fascinating to listen at Sherlock Holmes' work that you did in the hospital. So thank you very much for sharing it with us this morning. Yeah, and thank you to all the participants.
Yes, Francesco.
Yeah, please.
Yeah. Just to finish with a small joke. Yeah, Sherlock Holmes was a Scottish medical doctor, like Richard.
I know. That's why I mentioned. We have a second Sherlock Holmes. Yeah.
Or the author.
Okay, so thank you very much. I was just saying, we were just short 1 participant of 200, so well done for attracting a really large audience this morning, and we will announce the next data breakfast shortly. And later this morning, we will put the recording of this talk on our YouTube channel for those of you that might want to watch it again. Thank you very much, everyone. Thank you to the speakers, to the audience.
Thank you.
And, we will announce in the next data. Thank you very much. Have a great day and a nice weekend. Yeah, stay warm as well.
Thank you very much. Take care.
Bye.
Bye-bye.